Mechanism of ECG changes in hyperkalemia. The classical ECG change in hyperkalemia is tall tended T waves. In this ECG, some features due to hyperkalemia are visible. 1. Tall T waves. T waves in anterior leads are as tall or taller than the QRS complexes, though the absolute amplitudes are not very high. 2. QRS widening with right bundle branch block-like pattern. 3. Lack of atrial electrical activity. No P waves are visible and there is bradycardia. It could very well be a slow junctional rhythm. Ideally, if there was sinus arrhythmia visible in the QRS complex intervals, one could have presumed that there is sinus node activity with atrial paralysis and sinoventricular conduction. In severe hyperkalemia, QRS becomes very wide and merges with the T wave to produce a sine wave pattern, not seen in the ECG illustrated, in which there will be no visible ST segment. In a case reported by Ploegemann and associates, the patient was hemodynamically stable but presented with quadriplegia, had heart rate 45 per minute and had end-stage renal disease. Serum potassium was 9.9 millimoles per liter. Intravenous calcium gluconate was given and emergency dialysis performed. Sinus rhythm was maintained once normokalemia was achieved. Serum levels at which ECG changes are seen are quite variable from person to person. Potassium concentration within the cell is much higher than that in the extracellular fluid, which includes plasma. The concentration gradient is maintained by the action of the sodium-potassium pump, which pumps sodium out of the cell and potassium into the cell. Hyperkalemia decreases the potassium gradient across the cell and reduces the intracellular negativity of the resting membrane potential. Phase 0 of the cardiac action potential depends on the intracellular negativity. If the intracellular negativity is reduced, the rate of rise of action potential in phase 0 is reduced. This is because maximum number of sodium channels are available at a resting membrane potential of about -75 millivolt and decreases at lesser negativity. Decrease in the Vmax of the sodium current causes slowing of impulse conduction within the myocardium, resulting in QRS widening. P-wave duration and PR interval also get prolonged due to slowing of conduction. IKR, the potassium current responsible for potassium efflux during repolarization, is sensitive to extracellular potassium levels. Function of IKR increases with hyperkalemia, increasing the potassium conductance in phase 2 and 3 of the action potential. This leads to faster and shorter repolarization, manifest in surface electrocardiogram as tall peak T waves, the reciprocal of what occurs in hypokalemia. In severe hyperkalemia, there is absence of P waves, sometimes referred to as atrial paralysis. At the same time, sinus node still controls the ventricular rhythm, and this is known as sinoventricular conduction. This is because sinus node is thought to be more resistant to the effect of hyperkalemia than the atrial tissue. Theoretically, the existence of sinus node activity controlling the ventricular rhythm in the absence of P waves can be inferred from the respiratory sinus arrhythmia, that is, inspiratory increase and expiratory decrease in the rate. Here are a couple of references on sinoventricular conduction and sine wave pattern in hyperkalemia.